Love will find you. And who's that? I have two kids, a little girl named Bella and a little boy named Joseph. So I needed to take him to school, the daycare. As we were walking there, I actually fainted. I don't even remember it. I was severely anemic. I just kept attributing to the fact that I'm a new mom. I meet with my GI doctor and I walked in the room and saw her face, like she was clearly upset. And, I actually saw on the computer screen that, tumor, and I think it was 3.93 inches. And she had to deliver the news that I had a rare form of pancreatic cancer. She was so kind, and, she was crying with me. And I just said, I have a husband and I have 2 little kids. I have to live. When you're diagnosed with cancer, you instantly start Googling, but I stumbled upon the Lustgarten Foundation. The survivor stories were so inspiring to me. I actually found people that lived. And I remember reading them over and over and over again and saying, like, I'm gonna be there. I'm gonna survive. I'm gonna beat this. I'm gonna spread hope. Tomorrow's a new day. Anything can happen. Anything is possible. Tomorrow there could be a cure for pancreatic cancer tomorrow. That became my mantra through the rest of my cancer journey. After the 5th cycle of chemo, my surgeon said, okay, unfortunately, again, your tumor did not shrink, but I'm gonna go for it. My oncologist said, I just want you to know that only 4 hospitals in the country would have even performed the surgery that he did. He saved my life. I want to help other people. And again, I'm so grateful to be alive.
Thank you so much to Abby for sharing her truly inspirational story. Good morning and happy International Women's Day. Welcome to the first of our 5-part series of LustgartenLIVE events for 2022. Today, we are celebrating the power of persistence, women transforming cancer research. We are building on the success of last year's LustgartenLIVE events by broadening the scope of topics we will cover while maintaining our focus on research. Thank you to our presenting sponsor, ViewRay Technologies. A few housekeeping items before we start. Please type your questions in the Q&A box at the bottom of your screen, and we will get to them as we can. In the chat, you will find the link to today's symposium's agenda with panelists' bios. Before we begin, let's pause for a minute to reflect on the enormous suffering in Ukraine. Our thoughts are with all the women and all the people. We are in awe of their courage and resolve, and pray for peace. Thank you. Our first session is Multidisciplinary Care in Cancer Centers and Why It Matters. From personalized medicine to tumor biology, we want patients to be informed throughout the care continuum, which is why I believe this session is so important. I'm pleased to introduce our moderator on this first panel, Katie Kennedy of the 1440 Foundation, and our panelists, Dr. Christine Iacobuzio, Memorial Sloan Kettering Cancer Center, and a member of the Lustgarten Translational Advisory Group, Dr. Danielle D. Peralta, Northwell Health Cancer Institute, and Dr. Rosalie Sears, Oregon Health and Science University. Katie?
Good morning, and thank you, Linda. I'm so grateful to be here and to be on this panel with this amazing group of women doing such amazing work in the field of cancer research. And the topic today being multidisciplinary care in cancer centers and why it matters. But if you look at it, you'd say, why is Katie on this? Why is 1440 part of this? And I think what I'd like to do first is just start with a small story. First of all, 1440 Foundation, it stands for the number of minutes in a day, so now you'll never forget that. For the first about 6 years, 1440 was invested in well-being and social emotional learning. But that still isn't cancer, that still isn't multidisciplinary clinics. So why 1440? Well, in 2017, much like the video we just watched, the 1440 co-founder, Joni Krins, was diagnosed with stage 4 metastatic pancreatic cancer. It's as devastating as you saw in the video. It was as devastating for our co-founder, and it completely shifted where our foundation was going to put our efforts. But I'm going to jump forward to the present. And the present is that Joni is over 18 months cancer-free. So it's a stunning outcome, and it's the one we all hope for our families and our patients. So the conversation that I want to just talk about today is what happened in the middle. What was that process for her? So in the chat, they're going to put a link to Joni's story, which we've done in her husband Scott narrated and put together a story. So you'll be able to see all the detail there. And I'm not going to go into detail, but you'll be able to find it there. So Joni's cancer story began just like the woman in the video and used the same language, stumbling. She stumbled on experts. She stumbled on, and it was very much this sort of accidental destiny that she got through this process. She bounced from center to center. She found a few experts here. She cobbled together this team, and through that process, including finding a nonprofit that specialized in her cancer, which she felt was really key to her success, that she's come away with this amazing outcome. But she thought, why did I have to stumble? Why did I have to? Why was this so haphazard? What can we do? So as a result, she, Joni and her husband Scott, in our foundation, 1440 Foundation, created the Canopy Cancer Collective. And there'll be a link in the chat for that if you want more details on it. But basically, it's 14 different cancer centers around the US. They're pancreatic cancer centers, and they're working together to take the vision, take the promise of what a multidisciplinary clinic can deliver, and taking it to the next level. And it's through that process, we're now about 2 years in, these 14 pancreatic cancer centers are seeing really amazing results. It's the non-glamorous. How do we deliver to our patients a better care? How do we get them through the system faster? How can we refine our processes so they don't have to wait 7 days for diagnosis? So it's through all of these projects that these 14 cancer centers are working on that we are absolutely improving the way the patients are experiencing cancer care. It's not ad hoc. It's not sort of that stumble. And it's through the talent of these amazing physicians and doctors and healthcare providers, wellness specialists, that this is being delivered in a really coordinated and comprehensive way. They're connecting top medical care providers and wellness specialists and allowing them to operate at the top of their license. They're delivering mom level care, which is really our internal vision, is where would you send your mom? Offering hope and optimism. Again, reflecting back on the video we just saw, that's so incredibly important in a disease like pancreatic cancer, that this hope and this optimism is so key. And Joni would say having that positive attitude and an innovative care team is why it matters and why multidisciplinary clinics matter. And I'm so excited to talk to the team on this panel today about their work and learning more about what they're doing around multidisciplinary clinics and how we can all learn together. All right, I'd like to turn it over now to Dr. Iacobuzio. Dr. Iacobuzio, you've been working and understand the multidisciplinary clinic at Memorial Sloan Kettering. Could you talk about your role, your early role as a pathologist and now as a director, and how you've been able to impact patient care?
Absolutely. I'd like to start by thanking the organizers for including me in this truly wonderful event. I was an early beneficiary of Lustgarten support. So Lustgarten is near and dear to my heart, and I really believe in their mission. And before I answer Katie's question, I want to start with, my honest opinion about pancreatic cancer as director of the Pancreas Center at Memorial with 58 faculty, spanning the full range of the patient journey from diagnosis, management, radiology, nursing care, etc. I truly believe pancreatic cancer is a curable disease, and in 10 years we'll get there, hopefully sooner. And if I didn't believe that, I wouldn't be so committed to this job and working on this tumor type And it's really a pleasure to be on this panel with all these other outstanding women physicians and scientists. So I started my career as a GI pathologist, and a pathologist is a person that they're a type of doctor that you don't hear much about. They're behind the scenes. They are really a critical part of the team in working with surgical oncology, and Dr. DiPeralta will be right after me, working with medical oncology, and any piece of tissue that comes out of a patient, be it a biopsy, be it a resection, be it blood or fluid that has to go to lab medicine, there is a pathologist behind it who diagnoses that material and provides the information to the care team. The pathologist will, there's a saying that you don't have cancer until a pathologist, says you do, because kind of you need a tissue diagnosis often, or a blood marker diagnosis to proceed. So it's an important aspect of the care team, but it's one spoke in the wheel, and the wheel has a lot of spokes. Pancreatic cancer, I think cancer in general, is such a complex disease. Cancer care has become so complex, nobody knows everything. So that's where Multi-D comes in, is people, have no ego. Everybody is there to do the best for the patient. The patient is discussed, the images are reviewed, the pathology is reviewed. How is the patient doing? What is their, kind of status at the time? Do they need some support to help them get through therapy? Are they a surgical candidate? We talk about everything related to giving the patient the best possible care. Our multidisciplinary efforts, they happen at different levels. There are weekly conferences where all new patients are discussed, or patients that have a unusual clinical course and the group needs advice. But we also have quarterly meetings where we have information from each patient's tumor that is sequenced. And that's where science starts to come in, and that's where science and clinical medicine merge. So we review the genetics of a patient's tumor. Do they have something that, do they have a mutation in their tumor for which it might be rare among pancreatic cancers, but for that patient, there might be a drug that specifically matches the type of alteration in their DNA in their tumor. And we've seen cases of patients with remarkable outcomes simply by sequencing and finding these changes. We know through pathology, in looking at patients' tumors, or by performing some other kinds of assays, that we now know that pancreatic cancer can come in. I'm talking about, like, when we think of the worst form of pancreatic cancer, it can change its appearance, it can change its behavior. We're now learning that, and one is called classical, one is called basal-like. We're learning that depending on the type that a patient's tumor appears to behave, dictates how the tumor will respond to treatment. There are patients for which we've learned by sequencing their tumor that they might have had something special about that tumor that means they would respond to immunotherapy. So there's so many examples of how it can be done, but Multi-D has progressed from the early days, which is so important, all clinicians in one room evaluating each patient together, to now even expanding beyond the clinics into the research labs. And specifically at Memorial, we, on a quarterly basis, scientists and clinicians all meet together to talk to each other. The clinical stories inspire research. The research and the findings inspire ideas for how to design a new trial. And the net end result is looking to achieve the best possible outcome for each patient that comes through.
That's fantastic. Thank you. And what a great visual you gave us of what your multi-D clinic looks like. How do you guys share your learnings? Is it just in those meetings? Can you talk a little bit about, because that's what we're finding through the Canopy is the really key benefit is that you're getting that shared knowledge. How can you talk about that a little bit?
That's a great question. It's you know, I talk about this a lot of times as director. I'm trying to keep track of everybody's research, everything going on, what everybody is finding, and then when I hear something of interest, I make sure that it is presented at our quarterly meeting so everybody hears it. There might be a lot of emails and focused Zoom calls in the middle. And I think one thing we learned out of the pandemic, it's a lot easier to have a spontaneous meeting when people don't have to run from different buildings. So it's just a lot of communication and transparency, and just keeping kind of like your ear to the ground for anything that is new and interesting in light of what I know about pancreatic cancer biology. And so, you know, the collaborative net that we built, so I would say both within Memorial, but even outside Memorial. I mean, people on this call are people that I collaborate with, we collaborate with. So a lot of Zoom calls, I'm really looking forward to getting back to, hey, let's go get a cup of coffee, you know, and chat about science, because that's a really great opportunity to exchange information. So it's both informal mechanisms and informal, but you know, I just try to keep aware of everything, introduce people to each other who wouldn't necessarily know, and it takes off from there. You know, everybody has the same focus of we need to do something about this disease. And it's a wonderful thing to be a part of. Yeah. The pancreas community, I would say, physicians and researchers it's a wonderful community. It's very open, very sharing, very collaborative, very smart.
Yeah, that's for sure. We've definitely found that. We're so grateful to be in this community, as I said, from a patient perspective. Well, we'll turn it over now to Dr. DePeralta. And Dr. DePeralta is actually with one of our Canopy Cancer cohort partners at Northwell Health, and would be really interesting, since I described it a little bit, but to have it, you're on the ground, you're the one living it. You know, what is working, Dr. DePeralta, and can you talk a little bit about any of your successes?
Hi, Katie. Thank you so much for the question and for moderating. It's so nice to be on this panel with all these amazing women, and happy International Women's Day to all of you. You know, I have to say, one of the things about the Canopy Cancer Collective in 1440 that really struck me from the beginning is the way that they really nicely and succinctly describe their mission, which is to provide comprehensive, coordinated, patient-centered care across the trajectory of the patient's journey with pancreatic cancer. And the goal is really to improve quality of life, to ultimately improve survival, and to cure as many patients as we possibly can of this horrible disease. What we've been asked to do recently is really to hyper commit to this idea of providing mom-level care to all of our patients. And something that is so relatively apparent to us here at Northwell, where we have 23 hospitals across a rather geographically, socioeconomically diverse area, is that depending on where a patient presented, they may get care that's completely different. And they may not have the resources that someone like Joni or Abby had to make it to people who are experts, or make it to a surgeon who's one of, at one of 4 centers that may do this complex operation. So for the past 3 or 4 years, that's something that our health system has really focused on, finding a way to break down some of these silos within cancer care. We have a medical oncology silo and a surgical oncology silo and a radiation oncology silo. And what we know is that patients are often sort of shuttled between those silos, and sometimes it works really well, and sometimes patients get lost. And what we've worked so hard on is making sure that any patient anywhere in any of our 23 hospitals who's diagnosed with pancreatic cancer gets the same level of care. They don't have to, as Katie said, stumble across, the right providers, that we're making sure they're all getting access to the absolute best care to give them the best chance. So 1440, as the Canopy Cancer Collective, was sort of a natural progression of the work that we'd already started. And, initially the collective started with 6 sites across the country, and now we're up to 14. So now, rather than having our team here, we get to work with 14 different teams, so we can all learn from one another. And there are some centers that do some things really well, and others that are still learning. And now we don't all have to reinvent the wheel at every single stage along the way. We can sort of learn from each other. So we meet really frequently. We have a lot of small working groups. We're using this as a platform to ask clinical trial questions and initiate clinical trials, ultimately with the goal of getting patients the best possible care across the trajectory of their journey.
You guys were one of the first, and Dr. Joe Herman, who's on our medical team, he's our chief medical officer, comes from Northwell. Tell us, is there a specific example that you could give to folks about where you guys, because we haven't been at this long, it's only been 2 years, but where you've seen some real improvement? Is there a specific example you want to use that could give some tangible result?
So honestly, there are so many. It's hard to just pick one.
Love that.
So we were asked. We were one of 4 sites of the collective that was asked to be what we're calling an accelerator site to better define some of our core principles. And Canopy basically came up with 12 different principles that we think are key to driving high quality, efficient care for patients with pancreatic cancer. And we were asked to select 4 of the 12 that we're really going to do a deep dive and really focus on. So the 4 that we've selected are supportive care and palliative care for our patients, quality of life, using big data to drive high quality care, and development of what we call a neoadjuvant pathway. So I can touch maybe just a little bit on that last one, the neoadjuvant pathway. So as many of you probably know, our goal for patients who have localized disease is typically to get them to the operating room, to get their tumor out and give them the opportunity for a cure. And some patients, we know their tumors are amenable to being removed from the beginning, but many patients have tumors that are abutting major blood vessels and can't be removed right away. And what we found, especially when we're talking about those silos of care, is that the process from getting someone from their initial diagnosis to treated with neoadjuvant therapy, which is basically chemotherapy and potentially radiation before surgery, and then ultimately getting to the operating room, was not always as streamlined as it could be. And a lot of that depended on where the patient was geographically in the health system. Sometimes there were significant delays in getting the patients from their chemotherapy to the radiation to the operating room. And we know that, the timing really matters in these cases, and the follow-up really matters. So this is something that, in collaboration with 1440 and Dr. Matt Weiss, who's my partner and who's really driven most of this ever since coming from Hopkins, helped put together a pathway to help streamline this process for the entire hospital system. And now this is something that, we're sharing across the Canopy Collective. We have a surgeons working group that we're trying to, modify this, figure out how it's best to incorporate clinical trials into this pathway. And all of this with the goal of making sure that, the person that the patient's seeing in the office, it doesn't have to, it doesn't necessarily have to be me to make sure everything can work smoothly. It can be, it can be anyone. And if someone leaves our institution, if our coordinator leaves one day, that someone will be able to jump in to fill her shoes seamlessly without having to have a lot of delays. That's
great. Thanks. Thank you so much, Dr. DePeralta. And it's exciting to hear what you guys are doing at Northwell. I'd like to actually bring in Dr. Sears at this point, who's the co-director at the Brendan Colson Center in Oregon. Dr. Sears, thanks for joining us today. I'd love to have you talk about your work in cellular signaling pathways and controlling cell behavior that's leading your team to develop personalized care for your patients. And then we'll talk about some multi-D stuff later.
All right, thank you, Katie. And I just want to say it's a real pleasure to be here with all of you today and all of these amazing women on National Women's Day. And so, yeah, I want to talk a little bit about my journey and what we're working on here. So I'm a trained cancer biologist and geneticist. I've been doing basic research into cancer and really moved into the translational realm in the last about 15 years. We were very, very fortunate to be able to start the Brendan Colson Center for Pancreatic Care, which is part of the Knight Cancer Institute at Oregon Health and Science University, through a large philanthropic donation from the Norman, Linda, Brendan, and Colson Family Foundations. And this really allowed us to begin a vision of, you know, what can we do for patients with pancreatic disease, and particularly pancreatic adenocarcinoma. So we have three, you know, focus areas, which are going to be very familiar to everybody: early detection, precision medicine, and then quality of life and patient resiliency. I'm going to touch on all of those, but I'll start with what you brought up, that my work in understanding how cells behave and normally, and then how that gets disrupted in cancer. So people around the world, researchers around the world have been making incredible advances into our understanding of how cells are controlled at the genetic level and at the protein level, and then how we can maybe take advantage of that when a cell goes rogue, so to speak, and takes on new qualities that turn it into a cancer cell. One of these ideas is that the cancer cell itself is kind of living on the edge because it's gone rogue. It's taken on. It's got a lot of genomic DNA damage. It's got a lot of pathways that are turned on that are not supposed to be turned on, that the immune system picks up on. So there's a lot of hope for our ability to tap into these altered behaviors and this high level of kind of ongoing genomic DNA stress and damage. And there's new therapies, new targeted therapies that can take advantage of that. So, you know, one of the exciting things we're doing right now is trying to capitalize on that, on understanding how a cancer responds to therapeutic stress. We have a window of opportunity trial ongoing right now in which a patient with metastatic pancreatic cancer comes in, they get a biopsy. That biopsy is fully sequenced for its DNA, its RNA, its protein. It's analyzed spatially for all the different cell types, including all the different immune cells in that biopsy. And then the patient goes on therapy for a 10-day window. And it's a targeted therapy that's trying to take advantage of the ongoing DNA damage that the cancer cells are always experiencing. And then we get another biopsy, and then the patient goes on either standard of care or a directed clinical trial. And that second biopsy tells us how the cancer cells are responding to that therapeutic stress, how it might be trying to escape the therapeutic stress that will then really lead to combination trials, because I think we all know that we really need to attack this disease with multiple different drugs in our armamentarium. So that's one of the exciting things that our center is working on for personalized precision medicine. I want to give a shout out to all of the patients and their generosity in donating tissue and blood and undergoing biopsy procedures and all of that has allowed us to make so much progress in understanding this disease and coming up with better therapeutic approaches to target it. I want to just really point out the importance in all of this in my journey and in all of our journeys in this idea of multidisciplinary teams. And that is, I approached it from a cancer biology and genetics perspective, but I'm working with pathologists and oncologists and such. I co-direct the Brendan Coulson Center with Dr. Brett Shepard, who's our surgeon. We work closely with all of the different oncology teams, the radiology teams, and as director of our center, in terms of all of our translational activities and all those activities, how they funnel into clinical trials, I've had the pleasure to interact with physicians and scientists working on, for example, cachexia, the wasting that occurs for patients. And so we have a patient resiliency program, which includes exercise and diet, but also new therapeutic approaches to try to reverse the muscle wasting that pancreatic cancer patients observe. And then, our early detection activities are joined across the country with some national consortium, including the Pre-Seed Consortium that Diane Simeone is running from Pre-Seed from NYU. So all of these multidisciplinary activities that bring together people with a lot of different ways about thinking about a disease, I think really allows us to make progress. And I'm just very, very excited to be able to, as co-director of our center, really have my hands on all of these different aspects of the disease, and kind of like as Chris mentioned, you hear different things from all the different people, and you try to put them together,
right?
And get people to make progress with really the ultimate goal of really driving new clinical trials.
That's great. Thanks so much, Dr. Sears. I think it's encouraging from each of you guys. You talked about a patient resiliency part of it, and really that's what the focus for our organization has been, is how can we continue to support patient resiliency, and what's that care look like across not just the traditional medical fields, but including all those other pieces, a nutrition program, looking at enzymes, et cetera. So that's really exciting to hear, actually, that common thread throughout, and the willingness and innovation, which I think this needs. I think we'll turn over to Linda, who will help us lead in case there's questions that have come through the audience, and see if we can wrap up.
Great. Thanks, Katie. And thank you, Dr. Sears, Dr. Buzio, and Di Peralta for a great start to our morning. But I did have a question, and Dr. Iacobuzio, I heard you say this, and it is a thread throughout your discussion about how clinical stories inspire research. If you could comment on that.
Absolutely. So, again, as Dr. Di Peralta said, there's so many examples. I'll try to pick one. So, for example, we know about the BRCA genes that can be mutated in patients, particularly BRCA2, and those patients, Eileen O'Reilly, who's a medical oncologist at our institution, really leads our clinical trial efforts related to how to treat patients with germline or, somatic, which means germline means you have it, you developed it in your normal cells, and somatic means the mutations in the tumor. That's genetics 101. We'll put that aside. So, she has really interesting data showing how patients whose tumors have BRCA2 mutations, how they respond to a drug called cisplatin, right? And they can have remarkable responses. And, then it raises the question, why are they having remarkable responses? And some patients have mutations and they don't respond. And then other patients don't have a mutation, they respond beautifully, right? So, the question was, is it the tumor cells? Is it the cells surrounding the tumor, for example, the immune system, immune cells, or is it other cell types? And so given that what she was wondering, I connected her to another member in our center who is Dr. Donna Pear, who is an internationally renowned expert in single cell RNA sequencing. And the two of them met, they talked, Donna, who's from a very computational background, said, tissue's messy, it's not going to work. And, and then Eileen, from her point of view, said, but this is important. And anyway, long story short is now all of the samples from the first trial are now being analyzed by single cell RNA-seq. Donna Pear, who had no experience in pancreatic cancer, now prefers to work in pancreas cancer as one of her major tumor types of focus, because she's learned all these important questions that single cell can be really revealing. And that, it started from Eileen's observations with her clinical trial. Like Rosie said, me just hearing everything, talking to everybody, understanding that the ideal assay for Eileen's questions was probably something that could interrogate all parts of a tumor, not just one part, one type of cell. And then putting her in touch with Donna, and that's kind of started a nice research program, specifically single cell RNA-seq, of our clinical trials that Eileen is running. And so it's very exciting. It happens completely organically, from people just talking to each other and understanding and really knowing this is an important question. And we have the clinical samples, and let's study it and see what we can find.
Thank you, Dr. Iacobuzio. We are running out of time. We do have one question with regard to liquid biopsy, which we will either answer at the end or get back to the person individually. But just quickly, if someone could comment about diet and treatment after cancer diagnosis to decrease the wasting, and then any research being done related to primary prevention or recurrence if the cancer is caught early.
I just answered, so I'll let somebody else go.
Thanks, Dr. Iacobuzio.
I won't speak to the diet, as I think that a lot of that has been on, the Lustgarten Foundation has a lot of that information available to patients, and maybe Dr. DiPeralta can speak to that. I'll speak to maybe some innovative work that our center is doing. So we have one of the leading cachexia researchers in the world here, Dr. Dan Marks, and he actually approaches it from a different perspective. He approaches it from a brain perspective, as the cancer is actually talking to your brain, and this actually induces a lot of neural changes that cause the symptoms of cachexia, the lethargy, the loss of appetite, all of those things that go along with the wasting. And so he has innovative, we're just going to begin some innovative clinical trials with some new drugs that actually can affect those neurons that control appetite and lethargy and such, and awakeness and awareness. And so I'm really excited to pair those with our prehabilitation program, which includes the dietary and the exercise, and start patients on those early, be able to continue. They don't seem to have much side effects, these drugs, and so we could carry them through the course of the disease. And this would allow, the patient to be able to handle surgical resection much better, but also any type of downstream therapy for their cancer, because we all know how chemotherapy and such can be very difficult on a patient. And so if you deal with their cachexia and their resiliency, they can handle all of that so much better. And actually mouse models have shown that if you treat the cachexia and don't even treat the cancer, you can double the lifespan of a mouse with pancreatic cancer. So I think it's such an important field, and I'm so excited about it. And I really like Dan's understanding of it as more of a central process that gets deregulated.
Thank you, Dr. Sears. That was really, that was a very interesting comment. And I would encourage people who are watching to look at the research that's being done at Dr. Sears Institute if you want more information on cachexia. We are running really late. Dr. G. Peralta, I don't know if you had anything that you wanted to just chime in for a second.
Yeah, really just to echo how important the nutritional component is to all of this. This is, we incorporate our dietitians very early on in the diagnosis. Everyone who's getting chemo, everyone who's having an operation meets with a dietitian and has a nutrition plan as part of the neoadjuvant pathway. Patients who are getting chemotherapy before surgery, that's a great opportunity to really work on, increasing their performance status, optimizing their nutrition, focusing on high calorie, high protein intake. And then post-operatively, this is something our patients unfortunately struggle a lot with. So we really have to emphasize frequent small meals that are focusing on making sure that you're getting enough calories in. And I often tell patients, whatever you can eat, listen to your body. If it's ice cream that you're going to eat and that's all you can tolerate, then that's fine. It just has to be something that you can eat.
Thank you. Thank you so much. And thank you, Katie and Dr. Jacobuzio, Di Peralta, and Sears for an excellent session. And we're going to move on now to our next panel, Seeing Beyond, New Horizons in Cancer Research. There is tremendous progress being made in cancer research. It can be as big as the moonshot or something as groundbreaking as a 3D replica of a patient's tumor and how it can speed up treatment. I'm pleased to welcome our moderator, Dr. Nilo Azad, Johns Hopkins Medicine, and then our panelists, Dr. Jennifer Knox, Princess Margaret Cancer Center, Dr. Jen Ye, UNC Medicine, and Dr. Margaret Foti, CEO of the American Association of Cancer Research. Dr. Azad.
Thank you so much. It is such a pleasure and an honor to be here with everybody today and to see my friends on the panel who we haven't been able to see each other in person in some time, and I'm hoping that that's going to happen again soon. Today is International Women's Day, and I think that the topic today, the power of persistence, is particularly meaningful when it comes to pancreatic cancer and women in science in particular. I'm going to start off today. This panel is really about novel therapies and how we're going to move treatment forward with new treatments for our pancreatic cancer patients. And so I wanted to start a little bit with my journey, and I wanted to pick up a little bit on what Dr. Di Peralta said about silos in cancer research. I think that my journey into pancreatic cancer research is very indicative of how getting out of silos can be particularly helpful. I began my career 15 years ago, really focusing on colon cancer research at that time, and I had a particular interest in therapeutics in epigenetics, so using epigenetic agents in colon cancer. How could we use these agents to prime for other therapies? And luckily, I work at Johns Hopkins, which is a major center for pancreatic cancer research. And as we were learning from colon cancer and from melanoma, that epigenetic agents may particularly have impact on some immune cells, immunosuppressive cells like MDSCs and regulatory T cells, in particular in colon cancer, it happened to be a significant area of research at Johns Hopkins as well, in particular in Liz Jaffe's lab. And so we were able to come together 5 years ago with support from the Lustgarten Foundation, really looking in the laboratory with Liz's lab and Brian Christmas, who's a graduate student now, is a graduated PhD scientist, looking at these immunosuppressive cells, moving from what we had seen in colon cancer into pancreatic cancer. And then with the Lustgarten, we were able to move forward with a clinical trial in that space, combining epigenetic agents with immunotherapy. And really in that trial, that has been a seminal study for us, we were able to show responses in people with metastatic pancreatic cancer. And so that was the first time that we had seen that with epigenetic agents, durable responses. We still have patients on that trial from years ago that are still with us. And so, we've been working with this, leveraging that Lustgarten commitment, and now have a couple of other large grants where we're continuing to pursue how we could build on what we've done. So I think moving out of the silos, not just in terms of the field that we practice in, but also the different disciplines of science and how we can come together, has been something that's been really meaningful in terms of my journey into pancreatic cancer. And so with that, I'd love to bring some of our panelists into this conversation as well, starting with Dr. Ye as a surgical oncologist. So we are developing more and more therapies for patients, and generally we're testing these in the metastatic setting. A lot of times after patients have already developed significant resistance and resistance circuits have been upregulated. So I'd be really interested in hearing what your vision is for how we can move novel therapies up front and potentially in the neoadjuvant setting or in combination with surgical approaches, especially in this era of personalized medicine.
Yes, thank you, Dr. Azad. I think as everyone knows, surgery for pancreatic cancer can be really challenging for a patient. It can take a lot out of you and really be, there can be a really long extended recovery time. That's why it's so important to figure out, as you said, ways to really combat, not just combat the tumor in the pancreas, but also the insidious cancer cells that are hiding in the body. So exactly as you say, so how can we actually improve surgery outcome after surgery? How can we figure out what therapies to give in combination with surgery so that when we take the cancer out, it's gone forever? Because there is nothing more heartbreaking than seeing someone recover from surgery just to have their cancer come back. We know a lot more than we have in the last 10 years. The GI Protease trial from 2018 showed us that giving FOLFIRINOX after surgery can nearly double median survival for patients from 35 to 54 months. We know that from the SWOG 1505 trial that giving either FOLFIRINOX or gemcitabine nab-paclitaxel before surgery, that there is therapeutic equipoise, that those outcomes were similar for patients who were undergoing surgery. But that currently, I think, leaves us in a quandary. Currently, what we choose to give is really just our best guess. And so I think the big question is, can we do better than just guess? Can we actually somehow stack the deck in our favor? We know that people's tumors can be different. And so can we leverage these differences in the tumors to figure out the best treatment match? I think that is really the big question. As Dr. Yacobuzzi-O'Donoghue said in the last session, we know that patients with germline BRCA mutations respond better to platinum-based therapies, and that's part of the FOLFIRINOX regimen. Studies are underway to see if patients with KRAS G12C mutations are going to respond better to the new KRAS inhibitors. Our group has used RNA sequencing to find two major subtypes of pancreatic cancer. And both us and Dr. Knox's group have seen that perhaps patients with basal tumors are actually more resistant to FOLFIRINOX. This may mean that for the 20% of people who have basal tumors, that maybe the equipoise seen in SWOG 1505 may not be relevant. Could these patients respond better to gemcitabine nab-paclitaxel? Could they respond to an alternative therapy better? We don't know the answer to this. And of course, this needs to be studied in clinical trials to see if we can use something like subtyping or some other predictors of response as an integral marker to guide therapy selection. Dr. Susan Tsai at Medical College Wisconsin is actually doing this in the surgery setting. She is looking at whether or not subtyping can be used to select first-line neoadjuvant therapy, so therapy before surgery, in patients who have operable pancreatic cancer. And Dr. Knox will be talking about taking the next step in the metastatic setting. I think that in terms of trying to find treatment matches, this is true not only for surgery, but also in the metastatic setting as well. And I think the bottom line is that as more and more therapies are being developed, more and more technologies are being developed, we really have phenomenal opportunities to find better ways to predict response to therapy, or even our ability to predict success in surgery, for instance, through AI analysis of imaging. I think the ultimate goal is to really provide a bespoke guide, so to speak, right, for each patient.
That's a great segue into Dr. Knox's trial that she's leading, the PASS study that's been funded by Lustgarten with Stand Up to Cancer and Pancreatic Cancer Canada. Dr. Knox, you're the lead PI for this very innovative trial. Can you tell us a little bit about the trial briefly and talk about its potential impact in the care of our patients?
Certainly. Let me start by saying what an honor it is to be here with all these other women who are so important in cancer research. So I think of the PASS-1 trial as being precision medicine, the next round. You know, we've done lots of studies so far where we can tease out some genomic changes, and we've learned about BRCA and that. And now we want to try to add as much scientific information as we can in real time for patients, and then bring it back to the clinic to see if we can influence their care. So on top of all the genomic studies and even trying to understand signatures that Dr. Ye referred to, we've added in some tumor models, such as the patient-derived organoids or circulating tumor cells, where we're trying to do some really rapid drug sensitivity testing to try and see if that can inform what is the right choices for patients. Because as it's already been mentioned, we have 2 good chemotherapies in the metastatic setting, good in that we believe that they do help some patients and they have prolonged life, but they don't work for everybody. And the problem is they have side effects, and pancreatic patients don't have a lot of time to wait to find out that a treatment isn't working, because then it limits their chances to try something else. So on the PASS study, these are patients that have metastatic pancreas cancer, so the incurable ones at this point, and they get randomized between the 2 standard of care chemotherapy arms. But just before that happens, we get tissue to make the tumor models, as well as the all the genomic testing that we've been working on. And then at the 8-week mark, we take all that information pouring from the different scientists that are working in 5-6 different institutions at our tumor board. And we basically say, how's the patient doing, and what can we do? What could we do to make his or her treatment better? What could be an option for down the road? Should we change now? So we're really trying to just try to give patients as many options as possible. So just for an example, I can give you a very simple example of a man who went on the trial, was randomized to Gemabraxane. He's only about 60. At his first scan, it showed no response, but it hadn't grown. He was stable. But you can imagine there was quite a bit of nervousness about that, because, well, should he switch? Should he go on FOLFIRINOX? And I said, well, we probably shouldn't switch, because you haven't progressed, and FOLFIRINOX might not work either. But let's see what we get from the molecular tumor boards. And it turned out that genomically there wasn't anything to hang our hat on, but the PDO, the patient-derived organoid, basically said that of 30-40 drugs that we tested, the only ones that are likely to work are gemcitabine and Abraxane, which he happened to be on. So in a way, that gave us a little bit of reassurance to keep on it. Now, we probably would have anyway, but that gave us quite a bit of reassurance. And then he went on to develop a deep partial response by the next CT scan, and it's 14 months later, and he's still responding. So can we blame that on the PDO? Well, maybe not. Maybe we would have done that anyway, but it was very helpful in this man's case. And then in the meantime, they're doing more and more experiments with his organoid to try to understand some novel combinations and other things, other pathways that we could examine. So we have that in mind to move to at the time he progresses. So that's just one kind of example. We're learning all kinds of things as we go, and we're going to try to pull out any biomarker, in any patient that can try to inform better choices for more treatments.
That's such a great example, because I think being able to reassure patients that they're on the right therapy actually has extraordinary value as well. And then it also gives you time to see
To
how
do
their
more,
disease is
to
being
do more.
developed.
Yeah.
So just continuing on this trial, just because I think it is so important, when we think of the novel combinations that you all are testing, as patients move through their therapy, are they going to be able to have access to that? Is that something you'll be setting up over time, as it looks like there's pockets of many patients that might respond to a given novel therapeutic?
So as you know, the hardest thing about precision medicine is, the right patient, the right drug at the right time. So it certainly is, it is a challenge. And so one of the, when you look back at earlier precision trials, we might have recognized druggable findings, but the patient may not have been well enough to access the drug, or there weren't enough trials. So I think one of the things we've built into PASS is that it's being done in major academic centers that have a large, phase 1 and other clinical trial portfolio that have a lot of options. And so I think the beauty of it is that the patient may be responding on the first line chemotherapy, but we've got months now to plan ahead for what they might be able to go on second or third line, and get that kind of lined up for them, ideally on a clinical trial, but in some cases, access to a privately funded drug or something to try to extend those options. So all of that has been happening, and we've tried to plan PASS so that we can capture that kind of data as well while we move forward to see what patients went on a second or a third line treatment that was influenced by all the various correlates we're doing.
Wonderful. So President Biden just announced the Cancer Moonshot, the second Cancer Moonshot, which is going to be bringing all the different resources of the federal government to the mission of trying to conquer cancer. Dr. Foti, you have had such a unique perspective in your role leading the AACR over the last few years, many years. Can you tell me what the Cancer Moonshot means to you and what it will mean to our community in terms of cancer research?
Thank you, Dr. Azad. First, I too want to indicate that I'm very honored to participate in this special initiative of the Lustgarten Foundation on International Women's Day and in Women's History Month. So, these panels, it's so impressive, include some of the top cancer scientists and physicians in the world. And the information that's being delivered is really the collective manifestation of the expertise and the important work of women working in pancreatic cancer. So it's very exciting. I also wanted to say that it's been really thrilling to hear about the new opportunities currently available for pancreatic cancer patients. Unfortunately, I lost an uncle to pancreatic cancer a couple of decades ago, and he did not have the benefit of this, of today's cutting edge research. So it was really extremely interesting to hear what's happening today. It's really heartwarming that President Biden has made the decision to launch Cancer Moonshot 2.0. As the foci of this initiative are also those of the Lustgarten Foundation and the AACR. The scientific scope of AACR is very comprehensive in that it goes from basic science all the way to the clinic and includes cancer prevention, early detection, and population science. And we really look forward to the future cancer research, because we can say with some confidence that in order to have an all-out attack on this difficult type of cancer, any type of cancer, we really need to approach our work in a multidisciplinary way. So I was excited to hear the comments in the earlier panel from Katie Kennedy and others who really addressed the issue of multidisciplinary care, treatment and care. So as has been pointed out by you, Dr. Azad, we really need to think about pancreatic cancer and how we can extrapolate the knowledge from other types of cancer to pancreatic cancer and vice versa. So I'm proud to say that these synergies and having the Lustgarten Foundation and the AACR work together on these scientific and clinical challenges are going to really be very promising going forward. Our strategy aligns well with the Lustgarten Foundation, and AACR, for example, AACR has fostered investigations in all treatment modalities, but I'd like to mention that Dr. Liz Jaffe, who is our past president and also a major advisor to the Lustgarten Foundation, is really looking through a new initiative at AACR on precision combination therapy to bring together experts in molecular targeted therapy, immunotherapy, radiation therapy, and surgical oncology to really determine how these modalities in combination could increase survival in patients with cancer, all types of cancer. This novel approach holds really great promise for the successful treatment of pancreatic cancer. Now, of course, what we do in the clinic is very dependent on cancer biology, and we applaud your efforts to have more discoveries in that vein. Specifically to the Cancer Moonshot, the Lustgarten Foundation laser focus on precision cancer medicine, cancer drug development, clinical trials, and early detection is very important and very potentially impactful. Also, the research fostered by both of our organizations on cancer prevention, early detection, even cancer disparities, and really the lack of access to biomarker testing, screening, and health equity in some populations is absolutely timely as regards the Cancer Moonshot 2.0 initiative of the president. Currently, as you know, no effective screening or blood tests are available to detect pancreatic cancer. Imaging and early detection of pancreatic cancer really need to be markedly improved. And that's what this moonshot is really focusing on. So the Lustgarten Foundation, the Lustgarten Foundation's focus on early detection is right on target with the stated areas of President Biden's administration. So we really know that in order to make a major dent in cancer incidence and mortality, we must focus on these new opportunities in early detection. It's the future, after all, of cancer research. So we hope going forward that the NIH and the NCI specifically will be in a position to substantially fund promising research in the Cancer Moonshot Initiative, as there is a clear need for increased federal funding. To be clear, however, funding for the Moonshot is not available this year. It would be requested as part of the appropriations process for fiscal year 2023. Thus, I would say unequivocally that the generous funding provided by the Lustgarten Foundation continues to be more important than ever to maximize opportunities for improved care and survival. Thank you.
Thank you very much. I'd love, we only have a few minutes left together, but I'd love to talk or close our session by getting the panelists' opinion on if you had a wish list of what Lustgarten could invest in the upcoming years that could really advance the needle when it comes to precision medicine for pancreatic cancer, what you would recommend that we invest in. And I'll answer first so that I get myself off the hook. I think that a lot of what Chris was talking about at the last session about how we are learning to profile patients in much more sophisticated ways than looking at single gene mutations. We're now able to really profile patients based on their innate biology, as well as looking at broad profiles that include signatures that have DNA methylation changes, that have expression differences, that really look at mutational aspects and are able to use computational biology to put all that together and classify patients more than just whether they have a BRCA mutation or not. But the challenge is that we can't use this in a CLIA level way to select patients for trials yet. And so over the last 10 years, we've seen a plethora of papers in many tumor types where there are subclassifications of a cancer, but we aren't able to apply that clinically. So my wish list would be to be able to invest in moving those things forward in a way that we could actually use them to classify patients and enroll them on trials, and to go back to the data and specimens we have from old studies and be able to look at those patients and maybe from people who've already been treated, learn more about which ones would benefit and where we should be looking differently. So that's my wish. Dr. Ye, what about you?
Yeah, I think that's a perfect segue. I will say that, when we found the results of seeing that the basal RNA subtype patients were less responsive to FOLFIRINOX, the first thing that you think about is, well, how can we then intercept, right, and intervene and give patients a therapy that at least they have a better chance of responding to? And so I think your point of the CLIA assay is right on, because that was a huge learning curve. A lot of, I think, regulatory and bureaucracy on an institutional level that we had to learn and get over, with a lot of help and a lot of support from the Lineberger Cancer Center here to just develop a CLIA assay and get it CLIA approved. And that's what Dr. Tai is using at MCW for her trial. But that was really hard. I mean, after, as you said, after the publication, it still took a few years before we could get to the CLIA assay. And that's not necessarily because there was any technological hurdles. It was really regulatory resource hurdles. And so I think you're right that the foundation can help a lot with that. I think the other thing that what Dr. Knox said really hits home, which is the right time, right? We need to intercept earlier. There are multiple interception points that we can think about, whether it be before surgery, after surgery, before radiation, where we have these decision points. And can we be creative about clinical trials? Because something that we've learned over and over again, I think, with these big clinical trials is that there's potentially always a subset of patients that seem to do better with therapies. So can we figure out who these subsets are up front, and then create smaller clinical trials where we can, if we had these assays to use as integral markers, to go ahead and test them, because that would get the right decisions or better decisions and better therapies to patients that much faster.
That's a great point, and I hope we are getting closer to getting there. Dr. Knox, how about you?
So it's hard to add to those two great comments, because that's exactly what I think all of us feel. We've seen far too many sort of non-biomarker selected large trials in pancreas that are negative. And so we really do have to perhaps step away from that and try to do smaller trials where we have a strong scientifically driven hypothesis that we could actually deliver on. Now, having said that, I mean, in looking at large, pancreas cancer genomes and other data for the last few years, we certainly know that we can divide pancreas into different subsets, but I have to admit, we're not overflowing with therapeutics to offer them once we do that. So for example, the basal example, we know that they don't do as well on, in general, and they may do worse on FOLFIRINOX, but they don't do great on gemabraxane either. And we don't have a strong alternative. So if we were to devise a trial, what would that be? And so, there's some suggestions that they might do better with an immuno-driven approach and all of that. So we have to be brave in designing those trials in a population that does fairly poorly on chemo anyway. But Lustgarten should keep doing what they're doing. They should keep funding, this innovative kind of trial that is looking for new therapies, but in the non-large pharma driven kind of trial environment, where otherwise, I mean, my trial, for example, is not testing new drugs per se. It's testing whether the biology can be used in real time to influence patients. Would that be funded outside of, an organization like Lustgarten? So my point would be to try to keep up that kind of innovative support for new therapies. Thanks.
That's such a great point. It reminds me of the MGMT story in glioblastoma, where if you knew that you had methylation or not, you didn't have methylation, patients did better or worse, but there was literally nothing you could do about it. And so the development of drugs is really meaningful. But and Dr. Foti, I'm gonna give you the last word, as you always seem to get the last word. It's wonderful.
I love that
Go ahead.
last word.
Yes.
Thank you. So I agree with everything that's been said already. And I think in having the foundation invest in high risk, high reward research is very important. I did want to just say specifically that since mutant forms of RAS exist in more than 90% of the pancreatic cancers, that developing drugs that specifically target that area would be impactful, I think. So thank you.
Thank you very much. I want to thank all of the panelists for, I think, a really engaging session. And I'll pass the baton back over.
Thank you so much. Thanks to all of you for a truly excellent session. Last year, the Lustgarten Foundation committed to a multi-year investment in early career investigators via 2 awards, the John Lewis Career Development Award and the Ruth Bader Ginsburg Career Development Award. The 2021 RBG awardee, Dr. Danielle Engel, is giving today's Lustgarten Foundation Career Development Award lecture in honor of RBG.
Hello, everyone. I am truly honored to be here as the first recipient of the Career Development Award in honor of Justice Ruth Bader Ginsburg for my groundbreaking work in pancreatic cancer. RBG did not accept things the way that they were. Instead, she changed the things that she could not accept. In the face of adversity, she became the second woman to serve on the Supreme Court and had been breaking down substantial barriers for women since the 1960s until her death in 2020. I grew up in Nebraska, and I was a tomboy before I even knew what feminism was. The world felt like it was limiting me, like there were gender norms trying to restrict who I was before I knew how to name it. And sometimes that meant I fought with the neighborhood boys who said I wasn't good enough to play sports with them because I was a girl. And when I say I fought them, I want you to believe that I kicked their scrawny little bums for picking on me. Nobody even believed I did it, me being such a sweet little girl. I guess by the time I wanted to become a scientist, I was used to shrugging off sexist insults and expectations of who I should be and how I should act. Having gotten here, knowing what it takes, and doing my utmost to help other sweet little girls grow up to be in powerful positions themselves, I have a couple things I think I can offer in terms of advice for people who mentor scientists that identify as women. First and foremost, we need to create an environment where women feel safe and supported. I have had trainees who have left academia, not just because they have been undermined and disrespected, but also because they have seen how other people have treated me, a person who has been privileged enough and fought hard enough to be here. But still, in the middle of an office suite, I have been screamed at by a man for the audacity of asking him a question, for making him look bad. The audacity of someone like me asking a question. I have had amazing mentors who recognized my potential, who told me never to stop asking questions, but they were not there. However, in that whole office suite, no one came to investigate or said a thing. Even now as a PI, I have been interrupted and spoken over more times than I can count, often making it hard to even finish a sentence. No one again spoke up for me. No one said, hey, can you please let her finish? And I kid you not, during a particularly memorable meeting, I have even resorted to asking for permission to speak as if I needed it. This made me feel like what I had to say didn't matter, nor was it valued. How can we ever expect women to become scientists if this is how they're treated? If this is what they have to look forward to? We should not have to resign ourselves to facing daily microaggressions, outright sexism, or harassment to achieve our dreams. We need to make a concerted effort to treat women better and to hold others accountable. We need to understand what women experience, identify support gaps like access to childcare, and break down structural barriers impeding success in order to create an environment where women thrive, not just survive. So when you have an opportunity to be more than an ally, choose to be a co-conspirator and advocate. If you see someone speak over another, say something. Say that you would like to hear what they have to say. When someone repeats an idea that a woman has already stated, or when you are referencing discoveries in the field, make sure you refer to and recognize the contributions of women. In this day and age, we shouldn't see panels and conference speakers composed almost entirely of men. But just in the past 2 years, I have been to conferences where women make up less than 10% of the speakers. I have counted numerous awards and leadership positions for which women were not even considered. Make a conscious effort to overcome the implicit bias that we all have and nominate women for awards and to be speakers at symposia. Identify and address gaps in support for women. When women start their own labs, they are given a median level of support that is half what their male colleagues receive. Our own Women in Science Committee here at the Salk Institute provides funds for research and caregiving, but it is not enough. Not with the rising cost of childcare and lower salaries that women face. This is where awards like this one can help bridge the funding gap for women, and where advocates like you, like all of you, can take steps to make science more inclusive. My last piece of advice for all those supporting women in science is that when someone is being vulnerable about their experiences, validate it. Don't gaslight them. You may not have experienced the same thing. You do not need to agree with what they are saying or why they feel the way they do. But you do need to acknowledge that their experiences exist. Don't make people doubt their own lived experiences and how it makes them feel. If you invalidate someone's experience, you entrench the real harm that has occurred. When we tell you that we are being silenced, that others are doing more to appease oppressors than those that are disenfranchised, that actions in the community have had a real negative impact on our well-being, don't respond by saying that, well, you just haven't experienced that yourself. This minimizes or even attempts to erase the problem. 60% of women have experienced sexism within the last year alone. Discrimination is common, and it is real. As scientists, we learn to be curious and to follow the data. Well, the data is clear. Innovation comes from bringing together diverse perspectives. Being in an inclusive and welcoming environment is key for productivity. Exclusion and underutilization will always limit progress. Like RBG, I ask no favor for my sex. All I ask of our brethren is that they take their feet off our necks. RBG achieved excellence in spite of tremendous barriers. It makes me wonder what we could achieve in the absence of such obstacles. Since I started my journey, I have seen more women rise to positions of power and seen how they are lifting each other up. We are going to hear from a panel of exceptional, powerful women leaders in science who are inspirations to me and all women. That is how we change things. Thank you so much for your time today, and special thanks to every person doing the work to support the best possible science we can develop, which will take diverse perspectives like the ones coming up.
Thank you, Dr. Engel, for the excellent talk and for so powerfully sharing your journey. Today on International Women's Day, let's vow to work towards a world free of bias, stereotypes, and discrimination, a world that's diverse, equitable, and inclusive, a world where difference is valued and celebrated. Together, we can forge women's equality, celebrate women's achievement, raise awareness against bias, and take action for equality. Our next session is a positive start to fulfill this pledge. I'm pleased to introduce our next panel, Sharing the Journey, Fostering Growth Through Mentorship. I'm pleased to welcome our moderator, Dr. Summer Bizzuro of FCB Health and a member of the Lustgarten Board of Directors. Joining her are Dr. Danielle Engel of the Salk Institute for Biological Studies, Dr. Elizabeth Jaffe, Johns Hopkins Medicine and Chief Medical Advisor. And joining us again for this session are Dr. Jen Ye, UNC Health, and a member of the Lustgarten Scientific Advisory Board, and Dr. Margaret Foti, CEO of the AACR. Dr. Bizzuro.
Thank you, Linda, and welcome everyone. It is, wow, that was such a powerful presentation. Thank you so much for that, Dr. Engel. Just really well put. So I just want to get right into it. And my first question is, I would like for Dr. Jaffe for you to go first and describe what was one aspect of your journey as a scientist you wish to share with our audience?
Summer, that's a great question. Certainly there have been many, but I think the one part of my journey that I feel is very important and that I try to discuss whenever I can with early career scientists is the importance of understanding what patients need, to be talking with patients, to understand the point of view of a patient, to understand patient advocates. I think getting them involved early is critical on so many levels. It improves our science, it improves the questions we ask. But what I find in early scientists is that when they think about problems, they're thinking as biologists, as data scientists. They're thinking about the problem from the point of view of the science, not understanding what is the most critical problem faced by a patient with cancer. So I think that to me is probably the top of my list.
Thank you for that. And what about you, Dr. Engel? What's one aspect of your journey?
I absolutely agree. I think that, making sure that you're always considering the patient perspective and what is important to them is so critical. I also think it's really important as, visible women in science to encourage others, especially at younger levels, to become scientists or to consider it as a career. So for the longest time, I actually was not training to become a scientist. I went to college for music, and just knowing that that was even like a possibility earlier on in my career really didn't happen for me. And so I think that's something, a part of my journey that really speaks to like how we can be doing better to encourage more diversity in science by showing that it is actually accessible and that we value diverse perspectives.
Thank you for that. So we've all had a range of experiences in our career. I want to talk now about, I'd like to ask the panel to describe one experiences where you had an advocate, and that advocate could have been a male or a female, and how they helped you through a challenging situation. So I'll go first to Dr. Ye, if you could share that with the panel today.
Sure. I think that many people have preconceptions to surgery, and they're probably true. Surgery is a much more male-dominated field than even science in general, and probably one of the most male-dominated fields, I think, in medicine. Especially, we notice this as women as we move further in our career and mature in our career. So first off, I want to say, Dr. Engel, your video and what you spoke of was incredibly powerful. And I think that goes along with something that I wanted to share. I've been incredibly fortunate through my career since the beginning, that I've had so many mentors, phenomenal mentors as guides who've really guided me through my career in medicine and research. They've helped me with guidance along the way, opportunities along the way. I still have mentors from when I was training that I still reach out to now, and they've just been incredibly invaluable. But what I thought I'd do actually is share a more troubling experience. And I don't know that there was an example of an advocate in there, but I think it goes along with what Dr. Engel was speaking about in her video. And this was an interaction with a male colleague of mine, equal rank, who was, taller and bigger than me, which for those of you who've met in person is not especially hard to do. But he approached me in a really physically intimidating, like gruff manner. He was clearly angry. He was condescending. He approached me in a corridor that was off of a hallway. And I wasn't expecting this. I hadn't interacted with them. And what he had issue with was a clinical question that I had reached out to some of his colleagues for help with. And so I didn't see this coming, didn't have time to prepare. I was really taken back at how to react to this. And so my first reaction was, what did I do to offend him, right? What did I say that was wrong? And I'm not sure how I would have improved the situation or how the situation is improvable. But what really touched me, I think, at the end was that people actually reached out to me and to support me in terms of how inappropriate they thought that interaction was. And that was really helpful. And I think that was just personal reassurance for me. I didn't even realize that this was a witness incident at the time. And so I was just, I was perseverating over it and thinking about it. And the other thing that really hit home was that the people who did reach out to me felt that they needed to reach out to me in private because they were worried about repercussions in their own careers. And I think this goes along with what Dr. Engel said, which is so important, which is that I think numbers are important, supporting each other is important. I think that it's really a sad reflection of our culture if people do not feel like they can speak up to stand up for people. And I think that is something that today and this month, and I think in the future, that we are really trying to change. I think that what Dr. Engel said, just being in a meeting and reaffirming what somebody else said, or having a community of numbers that are in a position to make change so that when these incidents do happen, that there are advocates that can be of help to change, I think is incredibly important. So perhaps not a straight answer to your question, but hopefully will generate some discussion.
That's it's so important. And you're making me think about the public support versus the private support, because we do need advocates. Certainly as a woman, and then as a woman of color, I have many experiences to draw from. And in thinking about this question, the thing that popped into my mind, I went all the way back to when I was a graduate student, preparing for my qualifying exams. And I had written the first draft of my research proposal. We've all been there. We know how brutal that could be. And I gave it to my then advisor, and he waited until the last minute to review the document. And there was a moment when I walked into the lab and he had a ring of other postdoctoral fellows around him. And he was totally making fun of the first draft and, being very disparaging about it. And so it was a humbling and humiliating experience, right? To walk into a group of people talking about your work in this type of way. So later that evening, and it was a Friday, I still remember it, one of the postdocs from the lab, a man, called me And he said, you know, I did not agree with what happened, but he too did it privately. He did not do it in the moment, but he did call me and he said, you need to demand what you want from, you know, our then advisor. He agreed to take you into his lab to train you. You have your own NIH grant. You're fully funded. This is part of his responsibility to you. It's part of his responsibility to the university, and you have to demand it. And I said, but you know, what can I do? He's like, you need to call him, like hang up and call him. I said, but it's Friday, it's the weekend. I'll speak to him on Monday. He said, that's irrelevant. You need to call him now and let him know that he has failed you and you're a student, you need his support. And so I waited till the next day. I waited till Saturday morning. I called him up. I remember his wife picking up the phone, said, I need to speak to him, spoke to him. And I said, I can't do this by myself. I need your support. Obviously, I'm a second-year graduate student. And, you know, he was a pretty brusque person, but he did apologize. And he said, yes, I will do. And from that moment on, he did do what he was supposed to do. Was he always nice about it? No, but he did fulfill his end of the bargain and did review my work, review my dissertations, review my publications. And I learned in that moment that you cannot be quiet, you cannot be silent. You have to advocate for what you want, what you need in these situations. And if you don't, you know, you're just going to be sidelined. But I never thought about the fact that my advocate, who I always, and I still know to this day, didn't do it publicly, still did it privately. I wanted to ask if anyone wanted to comment about what Dr. Ye had to say or what I had to say in terms about finding advocates before we move on to the next question.
Well, perhaps I can add, we've all had experiences along these lines throughout our careers. And we have had the need for advocates, and in my case, male advocates to help me along the way. When I first became managing editor of the journal Cancer Research, I was 24 years old, and I replaced a man twice my age with twice my education. And he ran around and complained about how a little girl was going to be running the journal. And it was very painful to me, but I worked very hard to try to, obtain confidence of the community in that regard. Later on, when I became CEO, when I was in my 30s, I had another weird experience as I walked in the room of all CEOs. It was a CEO only roundtable, and I was the only woman in the room. And I was half the age of all the men in the room. And the speaker, the chair of the meeting, needed to reinforce the fact that only CEOs were allowed in the room. And I smiled and nodded and, got through that somehow. But the subject matter was really quite strange to me as a young woman, and that was how many years does a CEO need to give his organization when he decides he's going to retire? And the average number of years was, I don't know, 5 or 7 years. And of course, I addressed that at the podium because I thought it was totally absurd. So, we, in the beginnings of our careers, we all have, some of that. But I have to say that because I had male mentors, past presidents of the AACR, having confidence in me, even though I was still pretty young, vis-a-vis what else was going on in other organizations around the country, I have the position I have today, and I'm very grateful. And I think women need to think about how to really cultivate those collegial relationships with male colleagues, because unfortunately we still don't have enough women in senior ranks to be able to help them, and women need to rely on both men and women to guide them through these sometimes murky waters.
Yeah. Thank you, Dr. Foti.
And I'll just add my little part to this. We've certainly all experienced, as Marge and Jen and Danielle and Summers you've described. What I've learned, there were, as Marge said, both men and women can be advocates, and both men and women can be the ones who give you a hard time. And I certainly had my share of women as well. And when I look back, it's typically the first women who had to deal in this kind of environment that had the hardest time in my mind. And those women, some of them were, tough on the next generation because they expected us to be better than our colleagues, not the same, but better, just as they had to be better to be accepted, is what I learned from them. But what I found was that some of those women took a different point of view. The ones that took a different point of view were my advocates. They were the ones telling me, yes, you can have children and also have a very good career. They're the ones telling me, yes, you can be a leader. Yes, you can do this. Yes, you can do this. And I think that was very important. And what I've learned from them is I have to do the same. I have to be proactive. I can't just stand on the sidelines. You have to help other women. And I do dedicate my career to helping other women and also people of underrepresented minorities. As you pointed out, I think it's even tough now for people from underrepresented minorities. I think it's still tough for women, but we also have to be thinking about those who are from more of a diverse background who also have not had the benefits that white men have had.
Definitely. Thank you all for those excellent points and reinforcing the point that advocates can come from anywhere and so can detractors. I've also experienced that. So Dr. Foti, can you discuss some specific ways that you've advocated for a more inclusive environment at your institution?
Well, thank you very much, Dr. Rizzoro. I actually am very proud of what we've been able to accomplish at the AACR. And I'll say, first of all, that we all know that of course, the indisputable truth is that the professional success of women as scientists and physicians is absolutely essential for rapid progress against cancer. So as we think about the importance of these contributions, and our boards have done so, there have been some initiatives over the years that have been very exciting and I think very impactful. You all know, because you've been part of it, that there is an increasing number of women in the graduating PhD and MD classes, and it's frequently over 50%. And when I started at the AACR, we only had about 14% of the membership who was actually women. And now women represent 43% of the members and that's over 50,000 members worldwide. So I'm very proud to say that we have tracked our performance in terms of helping women through leadership opportunities. And over 46% of the leadership positions are held by women in AACR, as opposed to that of other scientific and clinical organizations that are actually as low as 7%. So this has to change dramatically. We have to continue to work hard to make sure that we foster this. And one of our mechanisms has been to actually form something over 30 years ago called the Women in Cancer Research. There's a council of 12 or so women who guide our efforts in terms of what we are doing professionally for women, and it's always exciting to sit with them and talk about how we can do better. And of course, the goal of fostering women is also discussed in our Minorities in Cancer Research Council, as well as the Associate Member Council. So all of these groups work hard to build the professional careers of women. And they've done a good job. But I think that where we have fallen down, I have to say honestly, is that when we ask for nominations of women for awards, they don't come through. People are not necessarily putting the time and effort into that, and also nominating them for even certain scientific events. So whether it be the Women in Cancer Research Council or other councils, we have to do better in that regard, and perhaps make it easier for people to really support the work of women. So we're definitely working hard at that, and I'm very happy that our annual meetings are showing enormous numbers of speakers, et cetera, who are women. But one of the things we have to face, and I might just add as an aside, is that women who are very prominent are being tapped all the time now, and they've accept all the opportunities. And so, Dr. Engel, you mentioned that one of the conferences you went to had only 10% women were speakers. We've experienced a situation here where we've tried to increase the number of women. We keep on getting refusals because they're so busy or they have personal conflicts, et cetera. So some of that stuff has to be, addressed, and we have to figure out how to better support women and somehow facilitate. But I think their participation. But I do think that the more women who are in the system, the more women who are recognized as great scientists and physicians, the more we can tap. Therefore, we will get to the numbers that we're working on. So our annual meeting looks very good in that regard. It's a level of something like 40% of the speakers, and so it's pretty exciting. I think we're working hard every day. We cannot lose ground, and I think we need to also, I might mention, help outright discrimination of women in other countries. Frequently, European women call me asking for help, as well as those in Asia. So there's a lot of work to be done yet, and we're up to it. And I'm thrilled that we've gotten where we have so far, but we still have more work to be done.
Thank you, Dr. Foti. Dr. Jaffe, what about you? Could you discuss some specific ways that you have advocated for a more inclusive environment at your institution?
Yes, absolutely. Really important question. When I came to Hopkins as a fellow, there were 8 fellows per year, 1 woman in each year. So we were really in the minority. When I came on faculty in 1992, there were 88 full-time faculty, 8 of them were women. So, and most of them assistant professors, even though they probably should have been associate and even full professors at the time. And so, I joined their group. We had a change in leadership, which was wonderful. And we advocated to the new chair of our department and cancer center director that this had to change. We came up with ways in which to make that change. I think taking on that leadership early on led to giving me more leadership responsibilities. And, I'm proud to say that as a division chief, I've built a program that has a significant number of women and people of color. Probably the majority are women and or people of color in our division. I'm now at the table. I'm the first woman to be at the table in our cancer center, the leadership table, as we call it. And you all have probably heard that, women in the past didn't make it to that table. And certainly in my department and cancer center, they had not. When I realized not only was I the only woman, but there was no one of color, every meeting, which was weekly, I would bring that up. We now have 4 women and 2 African-American men who are part of that leadership table of a table of 12 people. So, I feel like we have really come a long way. I've also led a number of women's leadership groups at Hopkins in cancer. That's my main area, of course. And we have an amazing, vibrant group of women who work together. We get together for seminars. We invite guest speakers. We talk about lots of different issues about women, underrepresented minorities, careers. This is a wonderful group, and we're all good friends. And it makes for an environment that is welcoming to other women coming through. And I think that's what's important. You have to show not only that you have women, but you have a welcoming environment for women to come through, and that everyone is promoting each other. And I think we have that.
Thank you, Dr. Jaffe and Dr. Foti. Okay, so what advice do you have for those who want to be advocates for women in science and don't know where to start? How about you, Dr. Foti?
Yes, obviously, the mentorship of women is absolutely essential. And mentors need to be, as along the lines of what Dr. Engel was talking about, accessible and supportive and sincere. It's hard because everyone is so busy, but it definitely is something that everyone really needs to involve themselves in. Interpersonal counseling, valuable networking opportunities. We also need to make sure that women understand goal setting and measures of accomplishment and work toward that and make sure that's visible. But I think one aspect to underscore here is to mention how mentors need to be motivating and inspiring by example. And another is to help mentees really obtain not only internal recognition as Dr. Jaffe has done, but also external recognition. There's such a thing called sponsorship versus mentorship, which I wanted to mention, in the sense that sponsorship is really the public support by an influential person for the advancement of an individual in whom he or she sees untapped or unappreciated talent or potential. And this is very important because sponsors can act as advocates at key career junctures, and frequently sponsors can do more than mentors. So I really want us all to think again about how, as more senior people who can be powerfully can powerfully work toward the career development of young people, we really need to think about being sponsors, not just mentors. And I think, as we look back on the history of AACR, the first female came in 1908, a year after we were born. By the way, we're having a big anniversary this year, 115. And Martha Tracy was inducted in 1908, and it happened to be that she was in a field that Dr. Jaffe is world renowned for. She worked with Coley, William Coley, for Coley's toxins. And as we look back on her, she did a lot of the work that he got a lot of credit for, but he did encourage her to join the AACR in 1908 as the first woman in the membership. And I think that if that were to occur today, I would hope that we would be further along. So I think we need to not only think about this as an opportunity to help science and foster women in the field, but also our responsibility.
Thank you. What about you, Dr. Engel? What advice do you have for those who want to be advocates for women in science and don't know where to start?
Definitely. Well, I think certainly follow the example of my fellow panelists who have been really inspirational in paving the path for women in STEM. But to build off of something that Dr. Foti brought up, is that this idea of sponsorship is so important. And if you need help figuring out what that means, Rosalind Chow calls it the ABCDs of sponsorship, right? Amplify, boost, connect, and defend. And different levels of sponsorship require different levels of public versus private support, but that's really how we kind of help support women to these leadership positions and help help improve the leaky pipeline, because as everybody has noted, we're not seeing as many women in these leadership positions, and so those that are overtapped and overburdened, and that leads to burnout. And so I definitely think if you can, pick one of those, all of those to be a sponsor for women in science, the difference will be quite large.
Thank you for that. Okay, so our last question, an important one. How do you pay success forward to other women in science? And Dr. Ye, if we can start with you.
Sure. I think just as what Dr. Foti and Engel said about sponsorship is incredibly important. And so personally, I try and be a sponsor as well as a mentor. I think it is incredibly important, regardless of whether you're at my institution or another institution, that we look out for opportunities for women and women of color. I think what Dr. Jaffe said about the generation before us, right? We're a generation that's sort of been through this, and the next generation is a little different, but we sort of know where some of the opportunities are, where some of the pitfalls are. So I think we have an opportunity to share that, so that the next generation is not really inventing the wheel, but have both external opportunities to be amplified, right, at meetings in public, and so that their work is noticed, and internal opportunities as well. And I think I noticed that some of this is just, it's sometimes it's just lack of opportunities. I think when you're starting out in science or you're starting out in medicine, you don't quite realize what the opportunities are out there, or perhaps what the steps of a ladder might be. You know, how do you get to that table? What do you need to accomplish to be the next leader of X department? What are the expectations? I think that's something that a sponsor can help with. And, you know, I think it depends on what the person that you're sponsoring, what their aspirations are, but tailoring those aspirations and understanding that so that you can help them with each step is incredibly important. And so I've been fortunate to I know a lot of women and women of color who are much smarter and much more successful, and will be much more successful than me, who hopefully are helped along with, you know, all the failures that I've had through my career, and hopefully we'll skip through some of them.
Great, thank you. Dr. Foodie, what about you? How can we pay success forward to other women in science?
Well, you know, I'd like to see more women do things like Dr. Jaffe in terms of, you know, being able to help other women. Whenever I've given talks at these meetings, where we've talked about supporting women in the field, and I mentioned that there not enough women are helping other women. I look at the audience and I see all the young women and some of the more senior ones nodding their heads. This is a rampant issue here that we have to face. And I was glad that Dr. Jaffe brought it up, because I think it's important. There's a slide I show sometimes, which was done by former Secretary of State, the special place in hell for women who do not support other women. And you can't just sit around complain. You have to help nominate, help support, and help sponsor. And so I'm truly hoping that will be a way that that women who are successful can really pay it forward.
Oh, so true. Dr. Engel, what about you? How do we pay success forward?
I think, you know, being sponsors and mentors, absolutely. But it's also this conception in science that you need a thick skin, that you need to be very outspoken and advocate for yourself. But a lot of brilliance and creativity is quiet. I was quiet, I was shy. And I quickly realized in order to survive, I had to become loud. I had to stick up for myself in a very forceful manner sometimes. And, you know, that directly combats a lot of stereotypes that women have to fight, that like, if you are outspoken, you're being too aggressive, because we're expected to be more modest and not as self-promoting. And so I do think that like we're in this unique opportunity where, as others have stated, it used to be that the trailblazers had to really be that level of fierce, but we can start to change the environment to be more supportive of women that are quieter, that are more shy, because they have just as much to bring to the table and to add to science.
Agreed. And finally, Dr. Jaffe, what do you think paying success forward?
Right. So I don't want to reiterate what others have said. I totally agree with Marge. And I think Jen has also said this, that we have to really make sure we're sponsors. And I've been on some of those committees where I've evaluated people for awards, and few women because they just were not nominated. So at a national and international level, we can really actively do that in addition to what we do locally. What Danielle said really hits home for me too. I think understanding that we're all different, regardless of, you know, color, backgrounds, even just personality. We're all different, and understanding these differences and being able to help women overcome some of these issues. I had a graduate student, my first PhD student, who had to get through her orals in order to continue her PhD work. And she did great on her classwork, and she failed her orals. And this was a time when I was called in by the council in immunology, and all men. And they said, well, if she can't get up there and talk in front of people, she should be let go. And I said, well, you know, wait a second. I said, and this is important that you really figure out what's going on. I said, wait a second. I said, well, when, and I had already spoken with her, when did she fail? And they said, well, she couldn't even describe her own project. So the first 5 minutes, that's the first 5 minutes of an oral exam, you describe your project. So I said, do you think there may be something else going on here? Like maybe she was intimidated, maybe she needed to warm up a little. And sure enough, you know, they agreed to give her a second chance. And she had an anxiety disorder, and she got some help for that anxiety disorder. Within 2 weeks, she went and took the same orals with this committee now, all of them who were around the table. And I got a call 2 hours later saying she passed in flying colors. Of course, she's now a successful you know, person in research, and she's doing great. So I think it's very important to know an individual's issues. We all have our own, we all come with different issues, different personalities, and one size never fits all in research, in life, in any career. So I always try to take that into account and try to help where I can so that women can strive, that all people, I mean, I do this with my male mentees as well. So I want to say one more thing. This is International Women's Day. And as Marge pointed out, we're luckier than people in Europe, than people in Africa, than people in Asia. Women in those countries have it much worse. And I just want them all to know that I think we all feel the same way. We're with them in solidarity, and the women in Ukraine in particular today. We're all thinking of them and wish them only the best, and want to help in any way we can.
Agreed. Thank you. Thank you so much, Dr. Ye, Dr. Foti, Dr. Engel, Dr. Jaffe. Thank you so much for your responses today. It's been a pleasure.
Thank you, Dr. Bizzaro, and thank you to everyone for this really terrific session. It's so important that we talk about our careers and talk about how we can elevate each other and support each other and ensure that there's women in the pipeline. And to what Dr. Engel said, fix that leaky pipeline. And Danny, I loved what you said, the ABCs, amplify, boost, connect, and defend. So thank you all. And if Dr. Knox and Dr. DiPeralta and Dr. Sears, if you can hear me, if you're still here, if you would turn on your cameras, we would love to get an International Women's Day screenshot so we can all celebrate the amazing work that you are all doing. And so, Glenn, I'm not sure Dr. DiPeralta is still here. So if you want to just go ahead and get that screenshot, and then we can wrap up. You let me know when you're done, Glenn.
I have it. Thank you.
Okay, thank you. So let me find my notes here again. So, so thanks for an amazing session. This was our first session of Lustgarten Live for 2022. We're looking forward to our next Lustgarten Live on Doctor's Day, from the clinic to the lab, or from the clinic to the lab to you on March 30th. Encourage our viewers to register. And to everyone who has not had a chance to see in the chat the program book, it is there where you can click on it so you can see our amazing panelists' bios. So thanks again to everyone, to our viewers, to our amazing panelists, and we'll see you all soon. Thank you.